My name is Debraj Shome, and I will be speaking about something which is my life's passion, which is facial aesthetics, facial plastic surgery, and facial cosmetic surgery. I started off my career as an ophthalmologist, but I was very clear right at the beginning that I wanted to use ophthalmology as a way to get into facial plastic and facial cosmetic surgery. Today, of course, many of you, or some of you at least, may be aware that there is a separate board for American certification, which is the American Board of Facial Cosmetic Surgery. There's also a separate board for the American Board of Facial Plastic Surgery. And it is basically ophthalmologists, people who've done residency in ophthalmology, in ENT, in oromaxillofacial surgery, and in general plastic surgery, along with dermatology, which basically venture into this specialty. Now, the face is something which comes as a holistic part. And I think that as we move forwards, all of us, of course, are standing on the shoulders of giants. And so from that perspective, every generation sort of figures a way to add to the knowledge that we already have. And because our seniors have trained us so well in oculoplastic surgery, I think the next logical step is to move to oculofacial plastic surgery and then to facial plastic surgery and facial cosmetic surgery. Because the face comes as a whole. Once there's a fracture, it does not really respect anatomical landmarks. We cannot just turn around and say that we will treat the orbit, but we will not treat the mandible, or we will not treat the frontal bone. So as a result of which, holistic care is important, and it's important to learn whatever we do appropriately from various specialties so that we can take the next steps forward. I think some financial disclosures need to be in place. I've been a consultant with Allergan, MERS, and Aptos. We run a chain of clinics called the Aesthetic Clinics, which is now in 8 cities in India. And acknowledgement is due to the dermatology team, which is led by Dr. Rinki Kapoor. Now, obviously, this is going to be put up on YouTube. I'm aware of it. But please do understand that this material is proprietary. It is very important not to copy any of this or use it without written permission. Now, facial plastic surgery is a fast expanding specialty of plastic surgery. I think the time has come when we should not just think of someone having complete control over plastic surgery of the entire face, of the entire body, because plastic surgery of the entire body can consist of hypospadia surgery, clubfoot surgery, craniomaxillofacial surgery, hair transplant surgery, rhinoplasties, and it's just too vast for any one person or any one specialty to be good at. And therefore, facial plastic surgery has become a completely niche super specialty. And facial cosmetic surgery now has about 350 diplomates from all across the world. And it gives me great pleasure and is a great honor for me to be the only American board certified facial cosmetic surgeon from Asia. Now, facial plastic surgery is divided into reconstructive facial surgery and cosmetic facial plastic surgery. And then we also have lasers and non-invasive procedures. And what I'm going to do with, after having taken the inputs of everyone at KGMU, is to take you through a small case-based presentation. So approximately 10, 12 cases where you see what we do, how we do what we do, and then sort of understand that there is a specialty which is beyond the traditional oculoplastic surgery as we know it in India, and understanding that it requires special training for the same. And of course, we run annual programs, we have fellowships, etc., which train people in this. So happy to contribute to your success in whichever way you think we can participate. Reconstructive facial plastic surgery is what we'll talk of first. And in that, trauma plays a very important role. I'd like you to see this video, please.
Last victim, which have developed post socket which remained. Since the nose and straighten the columellar broken to gain access to the nasal to the suture now look transcolumellar. This is the final patient now looks 6 weeks.
So if you think of this particular lady was a pen bomb blast victim in Iraq, and she had multiple fractures on the face. And once there were multiple fractures on the face, what she's looking for is to go ahead and get some form of redemption from everything that has been done. So we can actually transform her face. This was a transcoronal flap done, 37 bones in the face broken, entire team working on it. And that's her multiple surgeries later. So you can transform people in this manner. And I think
patient is a 32-year-old Iraqi lady who was a bomb blast victim. This case, the bomb blast.
In general, when we transform someone's face like this, what happens is they get a lot more confidence in life. and that is important. That's what we do. So what's on your face actually can affect what's inside the head. From that perspective, it becomes very, very important. This is, of course, many years ago and a much younger looking me. Now, the other thing that's happening is, especially in countries like India, we understand that we were all worried about COVID, which has been affecting the country for the past 1.5 years. But the fact of the matter is that almost 1.5 million Indians between the age of 30 and 40 every year die because of road traffic accidents. Indians are driving faster and faster. We don't believe in wearing wearing seat belts, and we definitely don't believe in wearing helmets. And the result is traumatic complex facial fractures like this. Now, if you see a patient like this, there's an IT person who's actually banged his car into a dumper. And when you look at something like this, you can see there are multiple fractures. So traditionally, if you thought about it, you would possibly call in someone else. But the fact of the matter is that the tripod or the zygomatic fracture is related to the orbital floor fracture, is related to the maxillary comminution. And unless and until someone sets all of this correct, you're not going to get the results that you're really seeking. So leaving some parts of it to some other people is a real disservice to the patient. And this patient underwent multiple surgeries, not perfect yet, with a prosthesis in the other eye, can actually get on with life. This patient has been on follow-up with us for the past 10 years, and it's gratifying to see him actually having moved on in life, having children, and taking the next steps. Now, when we talk of reconstructive facial plastic surgery, we are also talking of tumors like these, which we see all the time. So this is a basal cell cancer, and you can see that this is a pearly indurated mass, which is there on the lower eyelid. And the fact of the matter is, at this moment in time, in today's day and age, and as human beings move forwards, just removing this tumor and saving the life or saving the eye is not really what people are looking for. People come in with a desire, especially in metro cities, to look unoperated. So from that perspective, when you try and remove this tumor, it seems small, but once you've removed it, half the lower eyelid is gone, plus the lateral canthus is gone. That's a Frick's flap which is being done, and that's a periosteal flap which is being taken. And then you recreate the lateral canthus. Once you've recreated the lateral canthus on the table, you sort of see that both the edges of the eye look as symmetrical as possible, and they have a sharp edge, which is the unoperated look we're talking about. And the patient went from here to here to here, so that approximately in 6 to 8 weeks' time, you can see once the healing has been done, the only difference is that there are no lashes on the lateral part of the canthus of the right eye. This also we've now started solving, right? Because we can now do hair transplants in that area to actually give eyelashes as well. So the objective is to try and make people look like they looked before the cancer actually affected them. Now, this young lady came into us. And this young lady, when she came into us, she looked completely normal. But when you look carefully, you see that there is a swelling there and there's a little bit of pigmentation on the left cheek, especially seen on a profile view. When you have this sort of a patient on profile view, the reason that she's been waiting for such a long period of time is that she is not wanting a scar on the cheek. It's very simple to open up the scar, open up the cheek from outside, but leave her with a scar. She's 24 years old, and her question is, I'm better off with her statement is, I'm better off with the cyst. It's growing slowly, but I at least don't want a disfiguring scar on my cheek. So it's a very simple surgery, really. Once we know how to do this surgery, it's a question of going in and taking care of the anatomy on the inside and sort of removing the dermoid cyst from the inside, from an intra-oral sort of a route. Of course, there's a Stenson's duct there. There's the facial nerves there. But at the end of the day, you can do that. And once you do that, you can see the patient looks, this is about 10 days later, and you can see the swelling has been completely removed. And if you're very careful, you can actually decapitate and remove the entire cyst wall as well without creating a scar on the outside. Yes, there's a pigmentation on the outside, a pigmentation mark, a sign of a long-standing dermoid cyst and the pigmentary changes it has caused on the overlying skin. But that is something that will go away in due course of time. And you can also do pigment laser for the same. Now, talking about traditional things as well, let's see another video. orbital tumor being removed, and we all understand that that's something we can do through a transconjunctival route. Even if it's a really large orbital tumor, you can do like a swinging incision and sort of do it from the inside. The reason I showed such a typical sort of a surgery that we normally performed in any case is that now I think it's not justified to be trying to remove this tumor from a skin route. So therefore, the objective is, like I always say, every surgery is an aesthetic surgery. Whether that's an orbital tumor, whether that's anything else, it's not only the Botox that you do for your patients which makes them look younger, but it's about trying to plan every surgery in such a manner that the patient can be left without scars. There's an orbital lymphoma, of course, which is being delivered and removed. So also moving on to congenital stuff, and I'm also trying to sort of demonstrate traditional stuff here. And this we are all aware of. We all do it. We do a silicone rod, we do tarsofrontal slings very regularly and provide results very regularly. And we also do the LPS surgery very regularly, and we also do this. So basically, my presentation is about trying to kaleidoscope, especially from an ophthalmology and an oculofacial plastic surgery standpoint, what is traditional oculoplastic surgery and how we are looking to sort of expand the barriers in order to get ourselves given more skill sets so that we can solve more problems. These are, of course, the typical LPS surgeries that we have. Now, one of the things that we also end up doing is obviously we end up performing enucleation for patients of phthisis bulbi like this. But even when we do a enucleation, this, of course, was something that I learned in my fellowship at LV Prasad Eye Institute, when my first fellowship. And my dear mentor, my teacher, Dr. Santosh Honavar, taught me how to do a myoconjunctival enucleation. And then he very kindly allowed us to publish a paper on the same, which has now become the standard of care. And of course, the one thing that has changed with this sort of a technique is that you're able to use a 100-rupee silicone implant to provide these sort of movements instead of providing a calcium hydroxyapatite implant or a biointegrated implant like porous polyethylene, which is much more expensive. So these are some of the changes that we've been bringing about. Moving on to cosmetic facial plastic surgery, one of the surgeries that we like a lot is the mid-face lift. One thing that you would always understand is that human beings or Indians have a lot of melanin in our skin. So we have Fitzpatrick type 4 to 6 skin. And people who have Fitzpatrick type 4 to 6 skin do not necessarily have as much cellular or skin aging because of the ultraviolet rays of the sun, because of the melanoprotective effects of the melanin itself. So therefore, we don't really need a full facelift. And a mid-face lift is what we perform in a majority of our patients. And performing the mid-face lift can be done either through the transconjunctival route or it can be done through the intraoral route. Now, when we do it intraorally, what happens is we go in through the superior gingival sulcus. In this particular case, we've gone in through the superior gingival sulcus. We've sort of raised the cheek above the supraperiosteal layer of the maxilla. And we've taken 20 Prolene sutures through the cheek fat pads. And these have been then tunneled upwards. So they are tunneled upwards using a stylus by which we go through over the zygomatic ridge and then go through another incision above, which is behind the hairline. So now you have two incisions. One is inside the mouth, one is behind the hairline. So it is literally no visible incisions as opposed to a full facelift where you would have either a preauricular or a postauricular incision, which would be visible. And so once you've done that, you can actually see the moment you've taken this particular thing, you can actually see the left part is much higher than the right side. And the reason for that is if you think traditionally about aging, aging is basically all the tissues moving downwards and medially in the face. And so when you get the facial tissues to move upwards and laterally, that is anti-aging. And so when the fat has gone back to where it belonged, obviously the cheek looks higher. And you can see how the pull is transmitted. So these sutures, 3 sutures are taken. So it's like a triangular version, which is holding the malar fat pad up. And these are all tied onto the deep temporal fascia. And when you tie them onto the deep temporal fascia, you get a facelift through this mid-facelift technique. And this in turn leads to the facial tissues being lifted up significantly. And the results last for about 5 years. So it's a minimally invasive technique for causing a surgical facelift. This leads to people looking younger. So you have people who come in this manner. This is a 65-year-old man who came in from the United States and he wanted to look younger. And that's the patient after blepharoplasty has been performed, both upper and lower eyelid. A mid-face lift has been performed and carbon dioxide laser has been performed as well. So you can see it is not only about beauty. It is also about giving people redemption and making them look like they actually feel, which is much younger at heart. Now, carbon dioxide laser is something that we do very regularly. I'm sorry, I can't find the media for that. But basically, the carbon dioxide laser is a resurfacing laser. Earlier, the carbon dioxide laser used to be one which used to remove the entire skin. But nowadays, carbon dioxide laser is a fractional carbon dioxide laser, which means that it leaves islands of areas of the face where it removes the skin and islands where the skin is not removed. So the healing is faster. And the earlier complications like post-inflammatory hyperpigmentation, etc., are much lower. And carbon dioxide laser plays a very important role in facial rejuvenation and making all our surgical cases look better. Because ultimately, unless the skin looks better, we can do whatever surgery we want. The results are not going to be with the finesse that otherwise can be produced. Another of our patients having undergone an upper and lower eyelid blepharoplasty, having undergone a carbon dioxide laser and a mid-face lift. And we sort of discussed how this entire procedure is performed in the previous slide. That's the carbon dioxide laser being performed. That's something that we do a lot post blepharoplasty as well. After putting in a corneal shield, the carbon dioxide laser is done above the skin as well. And by doing it above the skin, we are causing the scars to become better. And we can also cause a little tightening of the skin. So sometimes you don't even need a blepharoplasty. Now moving on to the other injectable things that we end up doing. So now moving on to case number 14. This lady presented to us with a complaint of asymmetrical eyes. And you can see that the right and the left eyes look very different from each other. And you can also see, sorry for the way the watermark has been put in, but you can sort of understand. And you can also see that the right eyebrow is higher than the left eyebrow. So as a rule, whenever we see the eyes, it's important that you look at the rest of the face, because the rest of the face can give you important clues. And by looking at the rest of the face, you see that the entire right side of the face appears to be better developed and stronger, and the bone structure appears to be more convex compared to the right side of the face. You can also see that the right eyebrow is higher than the left eyebrow. So this patient is important because this patient had ended up going into some top oculoplastic and top plastic surgeons who had suggested that a ptosis surgery should be performed. Her main problem is that she is a model coordinator, and whenever she is in front of a high definition camera, both eyes do not look similar, especially when she smiles. So when she smiles, you can see how the left eye looks smaller than the right eye. But my question really to all of you is, can we really correct the 0.5 to 1 millimeter difference in the eyelids? And also the difference in the eyelids is because there's an inferior scleral show on the right side more than on the left side. So it's really not the upper eyelid which is causing the problem. It's the lower eyelid which is causing the problem. So instead of performing a ptosis surgery, she was not convinced that a ptosis surgery could predictably solve her problem. And so therefore, what she wanted was a non-surgical treatment. In this particular case, we did botulinum toxin. Botox was the botulinum toxin which was used. 2 units of Botox was used in the roll out here. Now, I know that you would all like to learn Botox and fillers, and we do a lot of courses, and I'll talk about them at the end. And also at the AIOS, at the DOS, and every other place, we do a lot of hands-on. So in the DOS, which is coming up on the 3rd of October, I'm doing a hands-on course for 2 hours. So if you would like to learn just the botulinum toxin and the fillers, that is possible as well. Please come and see us. But the objective of this particular talk is to showcase everything in its entirety. So from that perspective, 2 units of Botox was utilized in the lower pre-tarsal area in order to flatten the hypertrophic orbicularis oculi roll. What is the hypertrophic orbicularis oculi roll? It is this sort of a roll which is there in the under eye area. When a lot of people smile, it makes this eye look smaller, or it looks makes both eyes look smaller. And you'll see that in a lot of your patients. When they are smiling, their eyes become very small. And that's maybe not such a nice sign. So doing the Botox is a good thing. And then we did fillers as well. Fillers was done in the under eye area, and I will demonstrate how the Botox and the fillers was done in the next video. After we did the Botox and the fillers, that's how the patient looks after. Essentially, we took the patient from here to here. That is now when she's smiling, you can see that there is no roll. You can see both eyes look more or less symmetrical, and the patient was far happier. Yes, the fillers will only last for 2 years. Yes, the botulinum toxin will last only for 3 to 4 months, but it's much easier to be doing a repeat of 2 units of Botox every 3 to 4 months and predictably maintaining the patient's face rather than doing a ptosis surgery, which may come with its challenges and which may lead to overcorrection or undercorrection and the problems that we know as surgeons. Let's see the video now. So in general, in this, we have sort of demonstrated how even typical oculoplastic, oculofacial plastic surgery problems can be treated. I think it is a big disservice to our patients if surgery is all we are willing to offer. Every patient should have the right to decide what they would like, surgical or non-surgical. And by making sure that we have different tools in our armamentarium, we can keep them much happier. Now moving on to facial thread lifting, which is also a non-surgical procedure for facial tightening. So threads are basically non-surgical devices. They are like the stems of a rose, which have thorns on them. And once they are inserted, the thorns sort of engage the submalar fat pads and sort of raise the fat pads up. So it's a non-surgical facelift which can be done. Patients are completely awake. It's with prilocaine jelly that this is done in the doctor's office, and the results last about 2 years or so. In general, combining fillers, Botox, and threads, you can produce these sort of results. You are, as you can see in this particular patient, you can actually change the shape of the patient's face completely. You can put fillers and make the face sharper, and you can even transform her to the extent where she literally appears, this 48-year-old lady appears like her own daughter. These are some other rejuvenations as well. This is a very old patient of ours who presented at the time when only botulinum toxin and one of the fillers was available in 2006 and 7. And you can see, even if you know how to do just the botulinum toxin and the fillers, you can still transform faces significantly. And if you can do this well, then 80% of your patients will be happy even without facial cosmetic surgery, really. Other surgery that we do a lot is facial liposuction. In this, what we do is we use vacuum and a Lurelock syringe to sort of remove the fat from the lower part of the face. So as we become older, we are all aware that the lower part of the face, everything starts to droop. So the lower part of the face has more fat. So we remove the fat wherever it's accumulated and put it back where it came from, which is in the upper face. So this helps us to sort of restructure the face. And as I say, it helps us to reverse aging. In a patient like this who's got a very bulky face, facial liposuction helps, making it much more angular, making it much more symmetrical, and giving it much better proportions so that the patient looks far better in that sense. Orthognathic surgery is something which is a big strength of the group. So in this particular case, the lady presented to us because her face was too long. She also had some sleep apnea. So as a result of which we decided to do a mandibular setback, which is also called a bilateral sagittal split osteotomy. And it is just like the other drills and screws that you use for orbital or any other surgery, in which we're using a striker saw at this moment in time. These are the sort of significant changes which can be caused. Obviously, these changes cannot be caused non-surgically, so surgery is also important. Another surgery that we do, while I showed you how we can use fillers to sort of transform the chins, this can be also done permanently by using bone surgery, which is called genioplasty. Also rhinoplasties that we need to do. We need to learn that this is a very complex rhinoplasty in which we have used rib cartilage for broken nose. Also, I mean, as skills and repertoire increase, there are other ways of using the skills and repertoires. This is a typical Blepharophimosis syndrome, in which we use a new form of transnasal wiring, which we used to use in our rhinoplasties, and we now use it in order to do the transnasal wiring for these patients, leading to these sort of results. This is a Pakistani girl who came in, and as you know, blepharophimosis runs in families. From that perspective, the father is someone who also has the same problem. Now, hair is something which is very important, and as you might be aware, some of you may be aware, research is a very important part of who we are. There are 70+ papers that have been published in top-line journals. There are 2 patents which have been awarded to us for hair growth. This is now the QR678 is a product which has treated 21,000+ patients globally for hair growth, and has now got European Union as well as United Kingdom approval for use. It is already being used in India by our clinics as well as all the large clinics like Dr. Batra's, Kaya, etc. From that perspective, this is a mesotherapy-based injection which is utilized for administering to the scalp and for causing hair growth. And this has reduced our hair transplant rate significantly as we move forward. In general, especially because this is catered to residents, I encourage you to sort of publish and present regularly. I encourage you to talk about your work everywhere. And as you can see, we've been trying to expand the branches of aesthetic medicine all throughout with interesting papers on botulinum toxin, interesting ways of utilization of botulinum toxin, talking about problems like selfies being taken for Instagram and whether that leads to an increased desire to undergo surgery, finding mechanisms to use botulinum toxin for treating scars, which was the first time this was used. Ulthera is another thing that we use for non-surgical skin tightening, how we can make Ptosis surgery appear better, how we can go ahead and use injections to grow hair, how this compares with PRP or platelet-rich plasma in that particular sense, and so many other things that we've been doing. So in general, thank you very much once again